So I'm not sure how to get rid of this menu. I just wanted to give a really big shout out to all the giants that we've and all the shoulders of the many people that we're standing on today, not least the Action on Pre-eclampsia Society, really huge researchers down in London, Andy Shannon, Jenny Myers up in Manchester, and a whole other crew of people across the whole nation that's making this a big agenda. Just see if I can go to the next slide. So when I did this talk previously, a lot of the people that I gave a pre kind of presentation questionnaire out to said that they wanted to look at timing of delivery, trying to understand what the updates are for best practice in management, and also to hear a little bit about PLGF. So I'll try and talk a little bit about that, and Erum might touch and catch up where I've left off. You will in textbooks see the concept and understanding of why preeclampsia happens. And so the rationale or thinking is that the spiral arteries, which feeds the pregnancy and the placenta, develop this very nice, lovely, low resistance vascular system from the 16th week of pregnancy. And then this continues up to 23 weeks approximately. And in preeclampsia, this becomes disordered for a wide range of causes that's not fully understood. And so the consequence of this is maternal hypertension, the production of chemicals that causes the cells to become a little bit more leaky. So if you imagine that these cells are held together by the cell wall, they become a bit more leaky, and so protein leaks through, and that's how protein escapes into the urinary system. And because protein is a sponge which holds water in the vascular system, if protein leaks out, then water also leaks out, and that's why you get water accumulating where they shouldn't, and increasing swelling in the legs, fingers, and face. So the key messages from Embrace really are that we should work together as a team, and that's very clear. What that means in practice is that we have a clear process for knowledge implementation and advocacy, and being aware that the risks are not just for the mother, but also for the baby, working together with our midwives and our pharmacists with regards to patient group directives so that aspirin to prevent preeclampsia in high-risk women can be given more readily and more easily, to also ensure that the women's healthcare records are easily accessible and shared so that she herself has an understanding of what preeclampsia is and how to seek help and advice, because the vast majority of women may not have any symptoms with hypertension. And then I've also added down here about an awareness of how to contact the regional maternal medicine lead for any urgent services or advice. And we're very lucky in the West Midlands because we have a massive team comprising of Dr. Ellen Knox, who is our maternal medicine lead, Vicky Stroud over here, who is our midwife, maternal medicine midwife, who coordinates and acts as a liaison for us. So does Lynn Nolan, another midwife. We also have an obstetric physician called Parul Prinjar, and some administrative team support. So this is Sophia, who helps send out appointments, etc. And so this will be similar in your unit in your region. It's really just to find out who they are, to put a name to the face, so to speak, so that you can get help and advice when required. So kind of glossed a little bit about the pathogenesis of preeclampsia. And really, we have now some additional tests that we can do to further delineate women who have or have not preeclampsia. So in some units, they are now using blood tests called escalate and PLGF. Some will use PLGF alone. Some will use a combination of the two and create a ratio which gives a chance for preeclampsia, but it's variable across units at the moment as to whether this is being implemented or not. And this has taken us one step further beyond the blood pressure and proteinuria tests that we have available, with the idea that it can help us to identify the women who needed more targeted follow-up. I put this here just as a slight little icebreaker, because the slide is really meant to show that the risk of maternal mortality has fallen over the times, up until 2014. And it really is a demonstration of the collaborative efforts that we have in the UK that has led to this. So in 1996 was the first ever RCOG guideline for preeclampsia. I graduated in 2003, so there was a small plateau where there was no change, and then I went into Obs and Gynae, and there were new guidelines written, and then the rates of maternal mortality from antihypertensive disorders have fallen up until most recently. And with each iteration, there has been very significant change. And so, for example, there was a reduction in the hypertensive thresholds. And the 2010 NICE guideline brought the thresholds down from 160 over 110 to 150 over 100. And that made a huge impact on the number of women who died from preeclampsia or eclampsia. It has recently increased, and the reasons for that are not very clear. But I suspect that we are working in a slightly more complex environment at the moment in terms of the complexity of the patients that we look after, the systems that we are utilizing to give the care. And not all hospitals have the best of access in terms of simple things like electronic medical records, access to blood tests and results readily. Some hospitals have best practice guidelines incorporated within their EPR, which allows people to be able to engage more readily and more quickly with their local guidelines. And there's now another iteration or an update to the hypertension guideline, which has come from 2023. And this has lowered the thresholds for blood pressure lower from 150 to 140 over 90. And so the margins for intervention are much, much lower. With the intention of prevention of development of severe hypertension, if that makes sense. And when I sent out this questionnaire to my trainees, there seems to still be quite a lot of variation in how women are looked after with preeclampsia. So in some units, they were still being admitted. In some units, they were being managed as an outpatient, and there was considerable variation amongst consultants in the management of preeclampsia. And in some ways, you do wonder if that contributes to the outcomes that we're seeing, but it's very difficult to actually understand and pinpoint specifically without doing a national audit of preeclampsia to find out. So just kind of touching on PLGF very briefly, it's divided into red, orange, and green thresholds. So if the test, which is a very rapid test that so if you've worked in a unit which uses fetal fibronectin, actin-prom, or actin-partus for risk of preterm labor, then you'll be familiar with that kind of rapid access bedside testing, point of care testing. So a red line denotes a very low PLGF level, and that those women have a very high chance of developing preeclampsia within 14 days of the test. Whereas if they have a green line result, which means that they have a normal PLGF result, then they have a 28 to 84 days interval before they develop preeclampsia. So these women you may worry a bit less about. Just go to the next slide. Sorry, that's a repeat of the so this one is meant to show that when you carry out PLGF testing, if you do use it in your unit, then there are thresholds for intervention and thresholds for monitoring, and it's just important to find out what you do in your unit. And I thought we could finish off by talking about some cases, because on a very simplistic level, you do wonder, if it's so straightforward, why are we seeing the outcomes that we're seeing? And I'm happy for you, Hsu and Erum, to come off your mute, and then we can discuss the two cases that we're going to finish off with. So common kind of presentation. Community midwife sends a patient up to triage. She has a blood pressure of 144 over 92, which we know is to be high. She also has 1+ of proteinuria. But when she attends triage, she has a normal blood pressure and there's no proteinuria. Any thoughts?
So will we be having the participants writing in the chat box, or can we talk? How's that going to work?
No, I think it's probably as easy to talk, and we've got a few questions coming through already for later.
Okay. So yeah, basically, this is like pretty basic. You don't know the history. I think that everything is really important to know the history. We don't know the age of the patient. We don't know whether she's multiparous or primiparous. We don't know the BMI. We don't know singleton. It's multiple. We don't know whether, if she's multiparous, did she have a preeclampsia in her last pregnancy? Has she got a past medical history of chronic hypertension? Has she got kidney disease? Has she got antiphospholipid syndrome? Has she got SLE? It's a whole lot of things. So I think, what's really important is there is a problem. You have been referred this patient. Take a overall holistic view. What are the things that increase the chance of preeclampsia? What are you thinking about this? It's just one off, yes, but if you see the patient, any woman, any service user, you would need to take a comprehensive history. So you would need to know what it is with her, and then obviously you would like to repeat the blood pressure to see how it is. If there are any risk factors in a case, then you will arrange the care appropriately. You'll also ask her if she got any signs and symptoms, and you'll also examine her as well to see how things are. I think you have 144/92 1 plus of proteinuria, and then it is not there. You also would want to know what is the time interval between the referral to triage and did she come the same day? Did she have some children to sort out? Had she come multiple hours down the line? So I think unless you know all that and explore that, it's very you'd need all that to go ahead and actually formulate.
Yeah, and that's precisely absolutely spot on, because we want to have a conversation with the woman to try and understand her symptoms, her well-being, try to understand her risk factors, etc. But this is I would say, quite a common scenario, and then you can make a decision whether to initiate ongoing management and monitoring via the day assessment unit or pathway, or you may consider admission if she has any symptoms. You may want to consider doing blood tests to investigate if there's any dysfunction in her blood levels. But it would be quite easy to see how this could all go completely pear-shaped if that doesn't take place, because if it's busy, you think, well, actually it's normal now. She looks all right. CTG is normal. I'm just going to send her home. And it's very easy to do because it's normal, essentially, the blood pressure. But Erum's absolutely right, and that the history-taking examination is really important. I just also wanted to highlight the issues about follow-up, because we live in a very modern society, and we're very lucky and we're very privileged in the sense that we have smartphones, we have technology, etc. But there are people who do not, and there is a real concept of digital poverty, and those people are really severely disadvantaged because they don't have access to anything that will be able to give them anything from a contact point for follow-up. If appointment systems in the hospitals now are being delivered online through the app portals within the hospital setup, then that person is actually not going to receive their follow-up. And so it's trying to understand, you've given them the information, you've given them things to look out for when they're at home, but also you need to check their level of understanding and let them know that they require some level of follow-up and how that will be achieved. So I thought this was quite a nice one to kind of discuss together.
It's an excellent one. I think what other thing that's very important is that not stop doing this. So make sure that you emphasize it on all clinical encounters. Because, especially if the English is not the first language, she may not understand what you're saying. She may say, yes, yes, yes. So it's really important that you actually, talk about it on all the time. Tell her about red flag symptoms all the time. Ask her to repeat that. And the other thing is that I don't need many hospitals. So we actually have app, and we also have manual blood pressure. So we have a digital app for monitoring, which is Hampton app, and we also give them self-monitoring for those who don't have the same technology. So they just write it on a piece of paper, and there's a patient information leaflet that tells them what to do and who to contact, and then we have a standard operating procedure for follow-up. It's really important to arrange follow-up, otherwise none of these technologies are helpful.
And I think they do vary throughout. I mean, we've had some people on the chat box. Thank you very much for those who are interacting. Well done. And someone says, Maria Roundtree says, have both BPs been done during a manual BP or the same sort of machine?
Yeah.
And Sarah said, is this test undertaken by community midwives or the day unit? So it's some interaction.
I should point out that these are hypothetical cases that I've made up, and
Yes.
I know patients have come
Yes.
to harm with these cases.
Yes.
So PLGF is a blood test that's normally done in hospital. I do not know if eventually it will roll out to community midwives. I think that the idea of having it within the hospital setting is so that there is the added layer of investigations for assessing fetal well-being, such as by undertaking a CTG, or if the woman became more acutely unwell, as pre-eclampsia can do very rapidly, then there's rapid access to help and support if required. So I just realized my
I think
child
that's
was
a lovely, I think it's a
being
really nice
unplugged.
case study, Sue. I think that's really good because it really illustrates the complexity. And I think Erum is like a little detective. Both of you are sort of working the strings together here. Fantastic.
Okay, so I'll go to the next one.
Okay.
This one is a woman who's 36 weeks. She's having contractions. The blood pressure is taken at the peak of the contraction. She has 2 pluses of protein this time and also 1 plus of blood because she's had a show. Any thoughts? So is your background midwifery?
Yes, I'm a midwife. I'd
So
be sort of, well, I'd be thinking, well, when's the blood pressure being taken? Being very basic. And is the urine sample clean? This is very basic stuff, I know. And I mean, if she's having a contraction, her blood pressure is going to be up. And I'd want to be looking at her history. Is this new, or is this something that's been going on for a while? Has she been sort of cooking along? And all the questions really of before, of sort of her whole, the pregnancy, whether it's a primip or a multip, or whether she's got multiple pregnancy.
one of the things, and it sounds really crazy to think about, the simple things are so important, but time and time again, multiple reports actually say that because we've missed out on hearing the history, we haven't come to the right conclusion. And there is such a concept of diagnostic curiosity. Is this the correct diagnosis? And trying to recap the symptoms instead of making the assumption that it is what it is. And so we're all thinking along the same lines of, is this a pain-induced hypertension? Can we get a clean catch urine sample? Because she's had a show, maybe invasive as it sounds, a clean in and out urine specimen clean urine specimen through an in and out catheter would be preferable. And suppose she is in labor, then you might want to be starting to think about the ultrasonics that you might use for active third stage. Certainly for somebody who's hypertensive, who might have a very uncomplicated delivery. The active third stage, if they've been hypertensive before, should not include ergometrin, because that will cause her to have more high blood pressure, and that would actually be dangerous. One of the NICE guidelines, I think, we've just had a very new one a new update, where they've introduced ergometrin back for third stage management. But I think the previous iteration for the intrapartum guideline made it a universal practice that only oxytocin was used for active third stage. So it's really just to say, let's make a risk-benefit assessment of the situation, but because obviously if somebody's undergoing a PPH, that's not ideal, and you do need to stop the bleeding. But if there's been a history of hypertension in labor or at any point, then actually ergometrin itself might be harmful specifically. And it's really nice to try and keep things normal, shall we say? Because if things have been going so well so far, can we make things as normal as we can? But actually, escalation is really important, because remember, the thresholds for treatment for hypertension now have been lowered. And so if this woman persistently has hypertension, even if it is in labor, then she may warrant an antihypertensive drug lowering, so blood pressure lowering drug. Then you also might want to think about pain relief options and pain relief medications, Antinox, epidural. If they're thinking of an epidural, then the anesthetist usually want a platelet count before they do any administer any regional anesthesia. So that was that. Anything you wanted to add, Erum?
I would only say that it is really important. I've come across it quite a few times that the cuff size is not the correct one, and then it actually can affect. So I find that really, really important. And then, with this, make sure that it's with the right cuff. And once we make sure it's the right cuff, take the history, make sure there's nothing in the history that will indicate anything. Do a clean catch urine to see if, there's protein there. If there is, then send everything. And if you're thinking that it's not, just be vigilant because it could become something. So yeah, that's what I would say.
And then before I go, I just wanted to plug a little bit for the giant panda study that's running. It's running in my unit, and it might be interesting for some people. And so what was really fascinating is that there has been a Cochrane review demonstrate or about antihypertensive treatment in pregnant women, and it's fascinating, absolutely fascinating to me that the two commonest drugs we give, labetalol and nifedipine, have only really been evaluated in 354 women. So there's a really big study now called Giant Panda, which is a pragmatic, open-label, multi-center, two-arm randomized controlled trial. And what that basically means is that if a woman requires an antihypertensive, and they are between 11 and 34 weeks, they can be randomized to either labetalol or nifedipine when the clinician thinks they warrant a type of treatment. And the exclusion criteria is obviously if there are no contraindications, or they decline and don't want to be randomized, or they're already taking both and cannot be randomized. But I thought if it's not running in your unit and you wanted to be involved, you might want to contact the team in Manchester. And that's
Wow.
my plug for them. Thank you very much.
Is this intention to treat? So what happens if they actually weren't on it when you recruited them and then they ended up having it later on, the second medicine? Would they get out of the trial?
I believe it should be intention to treat. But what's really, I don't know what the data will show, because some people might start and be randomized to labetalol, not be able to tolerate it for whatever reason, and then have nifedipine as the alternative.
Or it may not control it and then have the pain. So
yeah.
I wondered whether it would exclude them later down, or would it just be intention to treat?
It should be intended to treat. Yeah,
that's what I think. Yeah, probably.
But I think all the data will be really interesting, because it might show that some people might be better off on labetalol, and vice versa, and some people might need more both types of medication.
Wow. Well, thank you so much, Sue.